Hello and welcome to the IFMA Benefit of the Month webinar, Exploring Spatial Risk, a Framework for Building Resiliency, hosted by the Corporate Facilities Council of IFMA. Our presenter today is Dr. Michelle Osman. I do want to let everyone know that they have been muted for audio quality and that this webinar is being recorded. If you have any questions during the webinar, please type them into the question box and we'll go over them during the Q&A portion at the end of the webinar. The recording will be available at the Corporate Facility Council's website, ifmacfc.org. You may also access past CFC webinars there as well. Again, that website is ifmacfc.org. At this time, I'm going to pass it over to the Professional Development Chair, Wayne Witzel.
Thanks, Joshua.
Wayne?
Oh boy, am I excited about this today. This is going to be great. I will say that I first heard Dr. Michelle talk on a Workplace Evolutionaries Zoom call that David Gray had put together here for our hub in Northern California. And what I found so interesting is her perspective comes from deep experience in healthcare and deep experience in architecture and design. And I thought, wow, what a great combination of skill set to be able to offer guidance and insight into this current situation. So having that expertise on both sides of that fence is going to be really helpful for us as we move forward into this world we're in right now. So without further ado, I would like to introduce you to Dr. Michelle Osman.
Thank you, Wayne. I really appreciate being here today. Well, hello, everyone. So today we're going to explore spatial risk. And the other title I once thought about for this talk is Managing Expectations and Managing Risk. Throughout my virtual travels, if you will, to institutions and corporations across the country, that really seems to be the message I keep hearing over and over again. How do we handle the needs and the expectations of our people and help them figure out how to get through their day safely? And so that's a bit of how we're going to spend our time together today. So in our conversation, we're going to talk about those extant models of health risk, how we communicate health risk, and how we can build resiliency by trying to make sense of that risk. And I do want to call your attention to some graphics you're going to be seeing throughout my presentation today, our conversation today, which is on the right. If you look closely, you can see that it says stay home. And this is the United Nations put out what they're calling a global call out to creatives to help stop the spread of COVID-19. And so folks like Harriet Can are using their skills to help communicate and quantify risk for people all over the world. So with that in mind, let's get started. So I'd like to begin by bringing up Florence Nightingale, and I could not start any conversation on spatial risk without doing so, who over 150 years ago articulated, can we avoid by any structural arrangements? I think it's really critical, that structural piece, any such excess of mortality, the great question to be decided by hospital architects. And I would speculate that very few of us on the call today thought we would be having this conversation as we think about a workplace. But what's so interesting here is that she's talking about the structural integrity. And to be clear, I'm not talking about whether the building will stand. What we're talking about here is the behavioral affordance, the cue that the environment is going to provide people who deliver care or people who are in a workplace. But moreover, that what is an affordance for a human being is also, interestingly, an affordance for a microbe. All those things that help us be together as humans is precisely the mechanism by which COVID-19 in particular seems to be happiest. So again, it's just fascinating to me that years and years ago, what was true is still true now. And so, by now, we're all familiar with these modified hierarchy of controls. I do like the modified ones that come out of Hopkins. I'm only going to touch on it briefly here because, again, I know we're all familiar with this. But again, this is from NIOSH as a framework to identify controls and to identify those workplace hazards. And it moves from the most to the least effective. And so physical distancing is the most, which you'll all be familiar with as elimination or substitution, to physically remove the hazard or replace the hazard. For example, we're seeing working from home and only having critical workers come in. the engineering controls to isolate people from the hazard, the administrative controls to change the way people work or redistribute work to reduce contact. Wearing a cloth mask technically is considered an administrative control, though we do see it confused sometimes with PPE, and then protecting the worker. What's fascinating here, though, is that when we think about hierarchy of controls, it's typically in the context of a workplace, but I would just argue here that what we've really done is trying to change how people live. You know, this woman is not at work. She is going about her business, trying to engage in what in nursing we would call activities of daily living, going shopping. And yet she is having to reconsider her entire life. And so I would argue that the behavior out of office is going to affect our behavior in office and is therefore much more in keeping with the behavior change required of a chronic illness or a long-term preventative health goal than an isolated hazard. So boundaries of risk. Contagion was really influenced by the environment of care. On the left, Florence Nightingale, years and years ago in Scutari Hospital, went out and discovered that the conditions were terrible. And I will say that at the time, it was assumed that death was essentially inevitable. And she was famous for drastically reducing death from infections. But interestingly enough, which she identified as the concentration of infectious people in one place, high density and poor ventilation. Now, I don't know about you, but that sounds awfully familiar and very similar to what we're encountering right now. And so what I also find interesting is how she managed to convince people, which we'll go and speak about in one moment, but I want to draw your attention to the right-hand graphic, which is of the Excel London Exhibition Center that got converted into an emergency COVID-19 hospital facility with 4,000 beds and delivered in just 9 days. Fascinatingly, many of these principles that were encountered years and years ago still persist and are part of what made our response today. But again, it's not just about finding out that there's risk or being concerned with risk, it's communicating that risk. And you may or may not be familiar with what is considered Nightingale's Rose. She was a statistician. And on the right, I want to draw your attention to the blue arrows. The blue areas are the number of deaths that are preventable from a preventable cause or an infection, something like typhus or cholera or malnutrition. The red were death from wounds, and the black is all other causes. So you can see by January of 1885, 87% of all the soldiers that died in Scutari died from preventable causes. Again, the typhus, cholera, and malnutrition. Within several months, 5 months after her sanitary reform, if you move over to the left-hand side of the graphic, you'll see that those blue pie wedges, if you will, have almost disappeared completely. And mortality went from being 32 to 42% annually to 2%. Again, it was her ability to communicate information, to communicate risk, and to communicate change that drove much of the change that we see even now today. And the Institute of Medicine in 2012 articulated that designing information to minimize safety risk is still an unsolved problem and is not as advanced in clinical medicine as compared with other parts of scientific disciplines. And this is still something we struggle with today, and we're going to explore more in our conversation. So establishing spatial risk. It's been clear for quite some time on the healthcare side that healthcare is inevitably and unfortunately a risky scenario. You may or may not be familiar with To Err is Human, which is the fundamental paper that came out in the year 2000, illustrating the almost 100,000 deaths that are lost due to human error, due to error in the system. And we now know through multiple papers and work that's been done throughout the years that the healthcare built environment is associated with reducing staff stress and injury, affects effectiveness and satisfaction, impacts infection rates, medical error and falls. Sleep and privacy can affect length of stay, determines patient communication and satisfaction, whether or not we use pain medication, are depressed or stressed, and social support. In other words, an array of factors have been independently associated with how it is humans indeed experience the built environment on the clinical side. And again, more and more we're learning about how this definitely has an effect on the office I'm sure you're familiar with Dr. Joe Allen at Harvard, who has a whole array of health performance indicators, as well as the work up the well building standards. Again, illustrating and demonstrating the effect of the built environment on human health in general. Now, infectious risk in hospitals, for example, is well studied. And I chose this as an example. In healthcare, we're really careful about designing clean and dirty areas, having sinks and hand washing opportunities everywhere. Air handling is exquisitely planned. Cleanability is a fundamental premise to how it is we design pretty much everything. Essentially, we have a culture of infection control. Don't touch your face. Your hair is up. I bet you how very few of you actually wash your hands before toileting. But we've established that spatial risk exists in hospitals. But there is a change now. To be clear, we haven't had to fear each other. We have only been concerned for our patients. That is a shift for us. But again, the culture of infection control is well in healthcare. Now, this is burgeoning in workplaces. Interestingly, on the workplace side, we have a culture of showing up, which perhaps isn't the best when we're trying to think about how to manage infection control. And of course, Asian countries are way ahead of us. In this one study, the purpose of it was to use viral tracers that behave very similar to the flu and to identify those frequently contaminated fomites in an office environment and to evaluate the impact of the hygiene intervention. And essentially, several surfaces really stood out due to their consistently high rates of bacterial phage, viral tracers, which in this case were the break room refrigerator, the exit door, soap dispensers in the women's bathroom, the sink faucet handle. This is to say that ultimately, infectious risk in workplace has been around. It just hasn't really been well studied. Now, we do know that, there are estimated 70 million lost work days due to absenteeism from upper respiratory infections per year, and 145 million lost work days due to presenteeism because of the common cold. But again, it hasn't been front and center in the way it is now. And I would speculate we may be seeing a reduced number of these types of infections in presenteeism and absenteeism in general because of the close attention that we're seeing now to things like respiratory hygiene and hand washing. Now, of course, with COVID-19, infectious risk is now here. This is a shot of the New York Times announcement that the WHO declared a global emergency on January 30th in 2020. Now, I'm not going to spend any more time, detailing on the response of hospitals. I admire the grace and courage of my colleagues all over the world who are taking care of patients. What we're really going to address is how it is and how it affected those of us in our regular lives who don't engage in healthcare practice on a daily basis. So stunningly, contagion and connection are now linked. And we sort of understood that this was the case. We knew the importance of food quality, food safety. We understood the importance of air. But it's become apparent that those things that we thought would only happen in hospitals could happen everywhere. There are stories of infections, stories of closures to prevent community spread. The possibility is real. We've heard the stories of the one unfortunate restaurant in China where the air conditioning unit managed to spread COVID-19 amongst a subset of tables. Now, I will say, though, interestingly, have we heard of any mass clusters or super spreading events in offices other than that one place? No, not planes either. Not to say it's impossible, the risk is there, but we certainly need to look at the full spectrum of risk across a person's day because intensity, frequency, and duration matter and has implications for your health. So where are we seeing outbreaks? We're seeing outbreaks in choirs. Unfortunately, Britain, Germany, the Netherlands, the US, and this month in South Korea, choirs and church services have been linked to outbreaks, as well as funerals and parties, these small gatherings. And again, it's the intensity, frequency, and duration. Are you singing, cheering, crying, or are you sitting quietly? The frequency, are you practicing the full Hallelujah chorus? Or only saying in a single exuberant hello or coughing occasionally? The duration, are you together 5 minutes, or an hour. Again, different activities crossed with different location will have a different degree of risk associated with them. But the fear is real, and people are voting with their feet, and certainly with government action, which is only supporting that. You know, across the country, the Mayo Clinic has reported seeing a decrease in new cancer diagnoses by 45%, reports of heart attacks down by 38%, strokes down by 30%, visits to EDs are down by 40%, and non-COVID-19 out-of-hospital deaths have increased. Now, the American College of Emergency Physicians is citing that 80% of Americans say they're concerned about contracting the coronavirus from visiting the emergency room. So, you know, fear is real. The risk is real, certainly. But again, considering the intensity, frequency, and duration is critical to helping folks really make a good decision and continue to live their lives. So now we're going to move over to models of health risk. And you may ask, why on earth are we bothering to look at risks? And the reason why is it's because it's through these epidemiological models that the prevention model of practice has evolved. This is why we have investigations into root cause, and it helps public health professionals effectively prevent illness, injury, and disability. The models help us organize our thinking and help us identify opportunities for intervention and whether or not we're having those effects. And furthermore, it helps us really pay close attention to what we're looking at and what we left out. For example, the social and physical components and how it is that impacts our health risk. So we're going to start with the epidemiological triad, which came about from Rothman in 1976. And to orient you to this graph, I'll show you on the left and on the right. So on the left, we have the host being you or I, right? Our age, our prior exposure, our susceptibility, our co-infection, our immune response, all have to do with how it is we will respond and the interventions that are directed towards the host, which in this case would be treating, isolating, immunizing, or providing nutrition. At the top of the triangle, we have the agent. This is COVID-19. So we think about, in general, the toxicity, the virulence, the infectivity, the susceptibility to antibiotics or antivirals, the ability to survive outside of the body. We've all heard a lot about that in terms of whether or not COVID-19 can survive on particular surfaces. And then on the far right corner, we have the environment, which includes the physical and the sociocultural, which is the climate, the physical structures, population density, social structures. And of course, there are interventions for this, such as the quality of the environment, sanitation, preventive services. But it's not so simple. You know, on the right, there's another way to depict this, which is to say that the environment is this sort of, lever, and the agent-host balance on them. So, you know, it's complex to imagine this. This is one of the simplest, but I bring it up because it is, and it does serve the basis for one of the most famous ways that risk and disaster is addressed, which is through Haddon's model, Haddon's matrix. And on the top, you'll see again the host of the personal factors, the agent, the vector factors, the physical environment, and the social, which we just saw. But what he did, he was a traffic safety expert, and tried to separate out those activities by their pre-incident phase, the incident, and then post-incident. Now, believe it or not, this has been used over and over again for folks that plan response across cities, organizations in the world. And this was done for SARS in 2005 out of Hopkins. And I show this as an example. So you can see here, let's stop on the top right, left. I put in SARS-CoV-2, but you'll see here pre-incident, you would engage in staff training, look at surveillance for public health, down to the incident, have mental health support, post-risk communication. If you take the time to examine each one of these boxes, you'll recognize what you're seeing now. So for example, under the physical environment factors, pre-incident, what is the availability of the PPE? Do we have infection control policies in place, the infrastructure, lab, surge capacity? And then down to the incident, who's designated? Are there designated crisis hospitals? What is the efficiency of the supply chain? All of these things should sound familiar, and the reason why is because folks who do this for a living have planned and practiced how it is we would respond to this. I do want to draw your attention all the way to the right-hand side, which is the social environmental factors, which is the part that we really struggle with. And I think what we're seeing now is, and you'll note that it has to do with organizational culture of adherence to protocols, cultural competency of risk communication. Where is trust, incident command, how it is that we communicate, ongoing mental health support, the economics effects on the community. And now I should say that, again, this model was designed for the pre-incident, incident, and post-incident. What is new here, what is novel, is that all of these things are happening all together all at the same time. Some of us are pre-incident, some of us are living in the middle of it, some of us are post. And so we're in a moment where simultaneously, within the same community, across the world, within the same company, within the same household potentially, every single one of these phases are happening, which again makes it really difficult for the individual, for the organization, to think about what one should do next, how to be resilient. And so because of that, we're going to look at the socioeconomic, the social ecological model of health. And the reason why is because, again, these are ongoing pieces and far more mimic the nature of a chronic disease rather than a single episodic event like a natural disaster, for example. So going back to the social ecological model of health, Felding and the U.S. Department of Health and Human Services described this with Healthy People 2000, 2010, 2020. I believe they're now working on the next version, which emphasizes the importance of the social and physical environment that strongly patterns disease and injury, as well as our response over the life cycle. And those are the full pieces, again, over the life cycle. And interestingly, Healthy People 2020 recognize the importance of those ecological determinants for health promotion, but they also model this in terms of addressing all hazard preparedness as public health. And so again, taking this approach as opposed to a pre-incident, incident, post-incident really allows us to think about how, as humans in community, we use all our determinants to work on an outcome. Again, in this case, it's health, but I do think one could substitute just about any organizational outcome, which is most certainly determined by individual behavior, social environment, physical environment, policy, place, etc. No, but we should define and make the difference between the model of health and an ecological approach. I love this because the ecological approach involves developing strategies to influence multiple levels and determinants of health. And interestingly, this comes from a classic piece from the Quad Council of Public Health and Nursing Associations, which is listed out again as the 8 tenets of community health nursing. Oh, and I do want to draw your attention to this graphic on the right, which again is part of the United Nations call to respond to COVID-19. But back to the 8 tenets of community health, which I do think you could substitute any organization to this, which is to say that first, it's population-based. The client or the tenant community or your organization is the population. And this means looking at the relationships, how the environment, how everything you're building is influencing community health, and how it is we can improve quality. The second obligation is the greatest good for the greatest number of people. What interventions can you make that will help the most? And furthermore, individual care is important and it is critical, which brings us to the next point, which is people are equal partners, how we can engage folks in self-care. So the health of your tenant, your company, community can only happen with participation, and behavior won't change without accepting and applying what organizations have proposed. In nursing, we always encourage autonomy and have this notion that we always say, never do for the patient what the patient can do for themselves. In that same way, here, I'm encouraging autonomy rather than permitting dependency, and encouraging people to have responsibility for their own safety. The autonomy is an important objective of public health, and recognizing that health information can be intimidating. Health literacy is notoriously low across really most people. So encouraging that self-care and how folks can really take their own agency and make a change in their own lives to, again, have a healthy approach to COVID-19. The fourth is prioritizing primary prevention, which is that health protection piece. So again, make it easy. Identify the high-risk groups and institute those preventive programs. Many of you are already engaged in that, looking for those environmental hazards. Now, there is the secondary prevention component, the early detection and intervention, which is why we're seeing all the screening that happens at the door or encouraging folks to stay home. But again, it is that primary prevention. The fifth is designing interventions for the whole community, not just those who are vulnerable or afraid or who can easily work from home or who can easily return or who have a single occupancy vehicle. Again, this is thinking about the entire population, the entire system, thriving rather than surviving. The sixth is actively reaching out, searching out those who might be at risk or who might benefit, and not waiting for those people to come to you. The seventh is optimally using your resources. So being a good steward. I can't tell you how often I find myself encouraging clients that we speak with, for example, don't do X, Y, or Z, because there isn't a lot of evidence behind it. We want to encourage communities and organizations to be thoughtful stewards of the resources that they have. And then lastly, collaborating with other professions, populations, and organizations. And this forum here is a perfect example of how it is you might do that. So communicating health risk, though, goes beyond just that communication. It also entails building public health capacity so that they can be enabled, encouraged, and empowered to act on their health risk. Now, as IFMA, all of those of you who are responsible for a tenancy, responsible for a building, responsible for an organization, certainly have that duty to afford and to help nudge, to create those settings that support health and remove those hazards. And I know from the conversations I've been in with many of you that you are actively engaging in trying to limit those hazards. But of course, any public health professional would suggest that while that's certainly part of it, we certainly need to create the scenario where long-term behavior change can be sustainable and teaching people how to interact within that setting. So risk perception. Risk perception, interestingly and not surprisingly, and communication work together. There's fascinatingly, the Finns in February of this year, the Finnish Institute for Health and Welfare, they decided to collect weekly qualitative data in real time that came in the form of social media posts and emails from the public. And they reported what they came up with for the first 3 weeks of their information gathering, got over 116 posts. And the five sets here on the left summarize what those points were from their community. And again, it was just the first 3 weeks. I'd be curious to see how that has evolved over time. But the first is the sense of a catastrophic potential and how does one respond? A great concern over the probability of dying. What is it? How do we know? The reasons for exposure. And with that, there was some, us versus them piece, which we've certainly seen across the world. A belief of being in control and trying to gain control. Again, you'll notice here, more pieces around the sort of public health perception. How can the individual be in control? And then this question of whether or not we can trust authorities and wanting to trust authorities. I love this example, and I bring this up because it may be a way to assess within your own communities and your own organizations, what is an understanding of the coronavirus? What are the perceptions of risk? What do people want to know? Since we are all individually and independently responsible for a body of folks. Because interestingly, it's super challenging. When I say recommendations for today, this is the recommendations from the CDC. This is a web archive from April 2nd, 2020. And you can see that the recommendations at this point were just to wear a face mask if you're sick. And if you're not wearing one. Now, this was in part because it's in short supply. But again, face masks were not recommended. And recommendations change tomorrow. Here we are, June 14th, where the CDC recommendations are that you wear a cloth mask anywhere and everywhere. So again, part of the struggle we have here is that information is changing, and rightly so. This is a novel situation, and we're trying to learn and figure out how to approach COVID-19, but the change in information can be at once confusing and can promote distrust, unfortunately. So having a model where we are able to engage in new information, bring it into our model and adjust is certainly part of a culture of resilience and a culture of adaptability. So I love the European CDC several years ago came out with what they were calling a new approach to communication in public health. And on the right, I want to show you again, this is from the United Nations Global Call Out to Creatives. And this was inspired by life in Southeast Asia by Asa Gilland and how folks can keep each other safe. But again, back to our new approach for communication in public health, you'll notice the shift from telling to listening. So risk communication being this complex process, and we need to be concerned with listening as much as providing information, which I think is really important for those of us who are in the business, essentially, or responsible for communicating to a group of people who are coming back to work. Have we listened to the concerns that our people have? And much can be learned from understanding what motivates them and what it is they're trying to get done. The second was information transfer to relationship building. And that is that risk communication is not just about an authority transmitting information to the public, but engaging the public, engaging populations early in development and planning and ongoing monitoring, the sort of exchange theory that we see from social marketing to encourage people to actively be involved as opposed to just taking, again, encouraging agency, encouraging control at the level of the individual. Moving from command and control to creating supportive environments. So risk communication, therefore, is not just about directive action, but making an environment where people can make their own informed decisions. And health promotion approaches are really good at this. So, for example, helping people make, I'm sure you've heard of make the healthy choice, the easy choice. We see this when we're designing placement of hand washing in hospitals, for example. How do we make it easy for a nurse to wash their hands? Well, maybe part of how we do that is we place a sink directly in the line of sight when you're entering or leaving a room. Or how do you make it easy in the same way for someone to use a hand washing, waterless hand wash in an office setting or in a workplace, potentially placing it on the desk to remove that barrier to action, or placing it on a more integrated path so that you're encouraging people to, again, making it easy to do the right thing. And then from a siloed to coordinated approach, recognizing that there are multiple actors and sectors that are involved with risk communication. And it has to be concerned with both integration and partnership, the sort of whole society piece, rather than something that is happening in one small group of people down to the rest, and instead coordinated across a group of people. So building community resilience. The increase in there is over time this increase in risk from the complexity of new and old threats. We have an increase in demand for efficiency in our daily lives. Emergency response systems need to be able to respond. And so how do we respond to this for a common goal, which is, I'm sure we would all agree, community resilience. And I write community, but I do think you could substitute just about anything. Building the resilience of your particular organization, building the resilience of a group of organizations that occupy the same building. You do in fact share that envelope. Building resilience of an actual community within a city in the typical way that we define it. We're building community in your home. Because again, all of these factors, how we move through our day, the spatial risk through our day, and again, this is spatial risk as Florence defined 150 years ago, and in terms of the intensity, in terms of the duration and the frequency. So I do appreciate how the RAND Corporation and others, there are numerous bodies who have thought about how to identify risk and how to think about our work. The RAND Corporation, I love this map, and we can start here at the top. I do want to take you through it. Brings us through disaster being in this dilemma where they are more common, the costs are going up, they are emerging, but how do we deal with it? And you'll see here that rather than preparedness, which we did address earlier, and we need preparedness, that certainly helps, But again, at the level of the community, is relationship-based. We just talked about that. Involves the whole community. Is long-term. Is ongoing. Based on our strengths. Broadly defined for a group of people. The sustainability piece is so important. And you know, I noticed the tie to the new normal, what will be new going forward rather than building back the same. And then how we get there, whether or not it's through wellness, through access to the different opportunities, education, engaging our communities in that active piece of participation, helping folks be self-sufficient. And I don't think we can highlight the self-sufficiency piece enough. Again, I keep hearing so often from my colleagues throughout our country, and increasingly internationally, that there's this great concern of what is my corporation, what is my building going to do for me? And that certainly is a part of it. We do need to take, where possible, the risk of human behavior, which notably is fallible, out of the equation as much as possible. But then that does leave you in this place of relying on others, as opposed to recognizing that there are activities, there are tools, there are pieces that the individual can engage in to respond individually and to be able to allow that person to adapt. So adapting for resilience. This takes a bit of practice, and I want to draw your attention again to this graphic on the right. This one is titled "Self-Isolate If You Feel Unwell." And this artist tried to show COVID-19. This is represented by the green shapes being transferred from an ill person to other people. So this adapting for resilience piece and a resilience-centered framework provides concrete actions for people. It's not just about what the government is doing for me, what agencies are doing for me, but allows and provides actions for the individual so that they can engage in sustainable activities and engage in that long-term well-being of their communities in the face of adversity and disaster. Now, part of it has to do with understanding the likelihood, understanding the consequences, and understanding the mitigation potential, which is challenging to understand. It's not nearly as straightforward as one would think, because of course, the likelihood of becoming infected, in this case with COVID-19, is not just about the virulence of said organism. It also has to do with your personal makeup. And there are some very interesting pieces out of the New England Journal of Medicine, most recently trying to present another visual framework to help people get a sense of, okay, depending on my age, my personal risk factors, how I should behave. But for the purposes of this talk, we will be talking more generally speaking in terms of overall likelihood, consequence, and mitigation potential. Oh, we went backwards. So I do really appreciate this piece that came out of Hopkins. I don't know how many of you are familiar with it. The Center for Health Security, about a month ago or so, came out with the public health principles for a phased reopening. And this was directed at governors as they imagine how it is they should open up businesses. And in addition to this subset, which I've shown here just as an example, they go across schools, places of gathering, of worship, of congregation. But what's so interesting here, and they do note that this is qualitative, there isn't yet a quantitative, probabilistic data set, which I know we would all like to have. But at this moment, a qualitative set that is certainly derived from a learned group of folks who tried to categorize physical location, again, spatial risk, against a hypothesized contact intensity, your number of contacts, and then your modification potential, which again, that's the piece where not only the organization arguably could take action, but so could the individual. And then they also provide the mitigation resources. Now, what's challenging here about this is that I can't really tell what to do with this. Okay, I go to a restaurant, it's medium. Where else have I gone that day? What else has a person done? Where else, how else has a person behaved? In what context? So this is where the visual communication of risk gets really, really important. Now let me draw your attention again to the graphic on the right. While I appreciate the designer's intent, this is an example of where visual communication is important and can be misleading. from this graphic, it really isn't clear. Is that one person supposed to be responsible for that many lives? You know, this is where graphs, to be useful, need to accurately demonstrate the risk magnitude, so how large or small the risk is, the relative risk, so you can compare, you know, as you saw before, if I go to a restaurant, is it safer than going to a bar? Maybe so. Allowing you to look at, for example, the cumulative risk over time. Let's say I go to a place that has a high risk in the morning, and because I did, I will try to take less risky behaviors in the afternoon. Cumulative risk. Uncertainty, right? Estimating that there's an amount of variability and a range. You know, there is that piece of it too. And then the interactions. I might be in a bar, but let's say it's empty, right? There are multiple interactions that take place, and how it is we can use visual communication to help us understand that. As we already saw from the work from Florence Nightingale, it's really clear that communicating information visually is one of the best ways to help folks understand what they should do, how they can behave, how they can mitigate their individual risks. So, scenario planning, the sort of risk journey. So, you know, resilient organizations also need tools that are resilient. And when I first started out, you know, preparing for our conversation today, it hadn't occurred to me yet that that's what this was really about. But I think that it is, and that we can build resilience in communities, but we also need to build communication that can resiliently move, that can adapt, that can change. Just for example, as we already saw, the work from the CDC, today it says don't wear a mask, tomorrow it doesn't. There's no mechanism in that communication method that allows for new information. So then the person starts to think, well, do they know what they're talking about? I have certainly heard that, and I'm sure you have as well. So how it is we can use visual aids to improve that risk communication and comprehension, to promote risk avoidance, and to increase trust and a willingness to participate in decision making. So to do that, one example might be a risk journey map. And I want to take you through this really quickly. And we've only got about 10 minutes left. On the left, if you'll notice, you have very low risk to low to medium and high risk. Now, to develop this risk journey map, I used the work that you just saw, the Hopkins work, which I very much respect and recognize that there may be others that are out there right now or that are developed over time. But as an example, how it is we can start to qualitatively but intelligently assign risk to different sorts of activities. Now, like most journey maps, this map moves across time on the x-axis and across activity. Now, you'll see at the top there are different activities, if you will, at home, in transit, being in a work area, taking a coffee break, having a group meeting, engaging in an after work activity. These different pieces could change for your organization, can change for the individual. You might expand this and explode it to include moving throughout a city. You might shrink it down to really focus in on your office. So on the bottom, if you'll note, we're showing here an example of a person in a single family home who's at a very low risk, in a single occupancy vehicle, that risk rising in the grocery, going back down when you're working from home, drive through lunch, etc. Now, interestingly, in this case, dinner with 4 cohabitants may actually increase your risk because they may have been going out. So again, this allows you to use a scenario planning framework to think about a risk journey so that you can adjust accordingly, take in new information, and change. So the next piece that we did here was to add on a second journey. And this allows, as we just visited, allowing one to compare different activities over time and allow one to adjust and see an accumulation. So for example, in this case, this person also lives in a single family home, but went into the office and took a 4-person elevator ride. Does that confer medium risk? Potentially. Here you are in a 6-foot separation, you know, adhering to all those recommendations that we heard about, maintaining that physical distance, using a shared surface that may have been cleaned, hopefully, which I'm sure you all are doing beautifully. Moving into medium risk if you engage in purchase lunch in a communal setting. And then, of course, that high-risk activity after work, which most folks don't have any control over, which brings you into that 6-person happy hour. Are you at most risk at that point? The last example that I'm going to show of a way that one might communicate resilience through a risk journey map is a different person entirely. One that might live in a multi-tenant home that's a shared entrance. So in this case, they're a low risk, right, because of the number of people that might be sharing that entrance. Moving up into a mass transit situation, which we know may be one of the highest risk places. Going back down into the office, which may be safer. Here we go into a medium risk, is that 3-foot separation work point. Are you really close and packed tight? I'm sure you've seen that study that came out of South Korea in the call center, where all those poor folks got sick from being packed into that office space. So are you moving into a medium risk if you do so? Safer because you have a home lunch at your desk, and then you have that virtual date, removing all risk because, of course, you're not exposed to any particular individual. And so cumulatively, what we're hoping this sort of map can do, and this is an example, we're trying to learn by doing in this case, is seeing how different activities, depending on your choice, again, giving the individual agency, allowing one to see, oh, I have the ability to adjust my work rather than choosing a midday meal in a communal setting. I choose a midday meal at my desk. Rather than engaging in mass transit, I might walk, which folks are saying is the absolute one of the lowest risks you can possibly engage in. Maybe if I have a number of comorbidities, I choose to work at home on a particular day. Again, the notion of combining an assessment of risk that is, yes, qualitative, but provides guidance over time to assess life, not just the workplace, but the full spectrum of life, so that we can be resilient, engaged in an active process of, I might be able to take control and change my behavior. By example, I'll say that Moss Design, which you may be familiar with, published a paper about several weeks ago showing some of the work they did with healthcare workers on a floor plan, and asked them to map out where it is they saw a safe spot within a patient care floor. And fascinatingly, it went all over the map. Some clinicians felt they were safe when they were just outside the patient room. Some clinicians thought they were safe if they were 10 feet away. Some clinicians felt that they were safe if they were on a different floor. It goes to show that safety and notions of safety really are very personal, and drawing maps like this one, or maps with actual floor plans, can help elucidate the mental model in your workers' minds, in your colleagues' minds, in your community's minds around what is a safe place to be? How is it that we might adjust our behavior? And what is real risk? Maybe just outside the patient room isn't really where you're safe, and you do in fact need to be outside, for example. So again, in this phase of COVID, we are iterating constantly. We are learning while we are doing. The intention here is that we engage in a process where we can take a map, where we can take a process, where we can take human behavior, take our need for visualization, take our lack of understanding of numeracy, and move to a model that allows us to, again, take agency and return to life to a certain extent. I'll close with an if only. If staying informed and getting the facts really was the change, really was the difference, I think life would be very different for all of us. But unfortunately, it's not enough, and we know it's not enough. Years of public health intervention has taught us that information does not drive behavior change. And so with that, I just draw your attention to, again, these 8 tenets from community health nursing, which remind us to remain population focused, to engage our partners, engage our people as equal partners in that self-care, look at that primary prevention, which we're all doing so well, design those interventions for the whole community, actively reach out, and use our resources wisely and collaborate with others. Thank you very much.
Great, thank you. If you have any questions, please feel free to type them into the question box on your control panel. They're asking where they can find resources. They really liked your mapping out the safety and risk.
Sure. Well, I would be happy to send actually, I don't know how you'd like to do it, but I'm happy to provide all of my resources that I use for this presentation.
Okay, if you send them to us, we'll post them to the CFC website, which is ifmacfc.org. Does that sound good, Wayne?
Yes. I also have some other questions. I guess I could summarize. And Joshua, I'm getting a little feedback, I think, from your phone. I guess what if I had to summarize these questions, they all center around the fact that organizations have a concern about making pronouncements about definitive things, given that everything is, like you're saying, iterative and changing, and they don't want to pin their advice to employees or guidance to employees sometimes on ever-changing information, because there is a potential legal risk around some of those things. How would you, I guess they're asking, how would you advise organizations to develop a plan that both assists in mitigation of transmission, but also protects the organization from potential risk and legal issues?
Certainly. Well, I think some things are pretty darn clear, right? Large droplet transmission, aerosol, hand washing, all those things are absolutely true. I think the bigger question is, for example, are different places in your building better suited than others? Just because you keep your office completely safe, which I'm sure most people are really going through the effort, doesn't mean that all your efforts aren't going to be thwarted because your people decide to go to an office happy hour. I mean, that I think is the bigger question. I mean, I'm not suggesting that that there's a sort of ever-changing piece so that you can't make changes or recommendations in your workplace. Certainly not. That's what hazard risk assessments are for. But it's more to say that it is not just your office. Your activity over the weekend is going to affect your potential virulency a week from now once you come back, right? So helping people think about all the choices that they're making throughout their life, and recognizing, of course, as you know, at this point, no organization can say, well, you can't go there, right? I mean, that's not part of the equation at all. So instead, helping people make sense of what the potential risk is, so that then they therefore decrease their risk to themselves and to the overall organization. I think that's the bigger opportunity.
So really then what we're dealing with is the potential, assuming that you have people mitigating their own risk and participating in this prevention, the asymptomatic person who enters the workplace is really the concern. And some of the other questions center around, let's see. Yeah, so obviously if somebody's going to come in that's asymptomatic, then the protocols and processes and office layout, direction of travel, all of those things are going to have to be designed around the asymptomatic person who doesn't know he or she is carrying this, but yet migrating through the office. So I guess there's a lot of people searching for answers there to say, tell me how I should do this. And I don't think there is any one way, but what is your input on somebody that's saying, look, we can communicate all we want, but what about that asymptomatic person that comes in? What should I be doing in terms of organizing the layout of my office and other measures to prevent that from exploding?
Sure. Well, again, the CDC is pretty clear. WHO, they're all recommending that we wear cloth masks for that reason precisely, right? That we know if you wear a cloth mask, I believe the data right now is 96% of all admissions are stopped. You get source control in that way. But again, it's really, really interesting. So when we think about contact tracing, for example, contact tracing doesn't even start until the 10 or 15 minute mark, right? I mean, walking past a person isn't deemed long enough to be even considered a person of interest, right? So that is, I think, some of the bigger issues here. Yes, should we design our spaces with 6 foot separation? Absolutely. Should we encourage respiratory hygiene? I think that the one-way traffic piece is going to be super challenging for a number of reasons. First of all, you're only moving past someone in a matter of seconds. secondly, I had some conversations with some folks at University College London about this, that really maybe the bigger issue is not the passing each other or the one way, it's that do you stop in the hall and start to linger, right? That might be the bigger question. So how do you make it possible for people to linger in a safe way? Maybe the issue is then not having single direction corridors, but having wide corridors, right? That get you at the 6 to 8 feet so that then you can stop and talk, right, with someone else. So, all those efforts that we're engaging in to redesign our workplace are certainly well worthwhile to help people both feel safe, to practice that physical distancing, to wear the mask, to engage. But, I just spoke with a colleague out of Hong Kong who said that, in Asia, they've not really made those changes and just wearing masks. So, again, much of this is cultural, and that's the part that we're not addressing, which is why I think it's so important to engage communities in a conversation, which is where public health has made the most strides, is not by just saying you have to wear a mask, but let's have a company-wide conversation around why we don't wear one or why we don't want to wear one.
I think that's a huge part of all of this is the fact that a lot of people don't understand the extreme potential of aerosolization of this pathogen is far more contagious than surface to person to surface or fomite to person transmission. That we really need to be concerned about the masks, and if we do that one thing, it's like a sledgehammer. It takes care of so much of these issues that all of this effort around design of the space and so forth, there might be overkill in that area. If we only use the masks, we wouldn't have to do as much of that. And I guess what we're seeing too is we have, and I call them armchair futurists that are cropping up around all of this, that are predicting the future with very little data points, it's conjecture, and there's no scientific rigor around what actual futurists and people like you do to kind of predict this future. But I want to ask you a question, and I've asked this of almost all the speakers we've had. Do you think that this is a, quote, new normal going forward, or do you think that we will pendulum back to the way we were or close to the way we were once we say get a vaccine or we get beyond, quote, this? Would you see this as new, we're always going to have 6 foot space and benching is going to go out the window, or are we going to go back to the way we were? What's your take on it? Because I know you're not an armchair futurist. You actually have background in this, so I'm anxious to hear what you say.
Well, my crystal ball is broken, but I do sort of have 2 thoughts about that. The first is that true immunity will make a lot more things possible, right? There's no doubt that once we know that we have a vaccine in place, it actually works and works over time, right? This is not the flu shot where every year, you just never know if it's going to work. It has to be meaningful immunity. I do think that could change. But the reason why I'm not sure we'll go back to a super tight benching situation, it has nothing to do with COVID-19. It has to do with the fact that I don't think people liked it to begin with. There's been so much work done. I've done it, others have done it on, for example, waiting room configurations. People don't like to sit next to strangers. They don't like to sit next to other people that closely. Now, this is certainly a Western phenomenon. I realize it's what I'm talking from, but people don't like the density. Crowding is stressful. And I actually wonder if the problem that we've been seeing with the open office has not been a problem with an open office. It's been the problem that we've had an open office and packed everybody together like sardines. So, I speculate that the 6 foot may go away simply because people prefer having more distance. They have a little more spatial separation, which is typically what folks prefer in other social settings. And then the emergence of technology, which makes working from home really possible for lots of people. Now, certainly depends what you do. But I'll tell you what, I am watching legislation really closely because I don't want to have to go back into my doctor's office for a medicine check. I want to be able to do it remotely. And so those 2 factors together, I think, suggest that we may not be going back to as tight of an office as we have right now, or had previously.
Got it. Well, I would just like to first of all, Joshua, thank you and IFMA HQ and Components for always helping us put these webinars on. For those of you who are not members of the Corporate Facilities Council, please consider joining. This is the kind of content that we produce, high quality content throughout the year. You can go and join councils through the IFMA.org website. And lastly, Dr. Michelle, I'd like to thank you. This has been very informative. I'm a science geek, and I really appreciate, and Edward Tufte would be very proud of your risk journey map. I want to send it to him just to say, look, there's hope for graphics. So thank you so much for this presentation. We enjoyed having you, and we appreciate everything that you've presented today.
Yes, thank you for your time. It was a pleasure.
Thank you, everyone.